You cannot sit through a movie. 20 minutes into a drive, you are shifting hip to hip, then pulling over. The pain sits deep in the buttock where your thumb cannot reach. And somewhere in the last year, someone said the word sciatica and started sending needles into your lumbar spine. I am Dr. Padda. Sciatica is not a diagnosis. It names a root, not a source. Three structures produce that same leg pain often enough that I look for them first, and two of them sit outside the spinal canal entirely. The hip joint, the sacroiliac joint, the gluteal tendons, and a narrowed canal can all counterfeit it too, which is why the word sciatica should never end an evaluation. If your generator is outside the spine, every needle placed inside it is aimed where nothing is wrong. Here is how it happens, and I see it constantly across St. Louis. You get an MRI and it is not blank, because almost no adults is. Findings become the explanation, because the picture already exists, and an examination costs time nobody budgeted. Nobody presses the back rim of your pelvis for the point that reproduces your whole leg. Nobody asks the question that actually sorts these three, not whether sitting hurts in all of them, but where it hurts when you sit, and whether anything below your knee has gone numb or weak. You are booked for a series instead. When it fails, the conclusion is that your case is complicated. Almost never that the target was wrong. Generator 1 is lumbosacral radiculopathy. Disc material displaces out of the annulus and mechanically compresses a nerve root as it exits. Compression is not in dispute. It produces a conduction problem, numbness in a defined strip of skin, a weak muscle, a quiet reflex. The other half of the story is weaker. The idea that escaped nucleus pulposus chemically inflames the root on contact comes largely from animal experiments. It is plausible, but in humans it is inferred, not demonstrated. The clinical pattern, leg-dominant pain following a dermatome, usually below the knee. Worse with coughing, sneezing, or straining. Generator 2 never touches your spine. In deep gluteal syndrome, the sciatic nerve is entrapped after it leaves the pelvis. Tethered by the piriformis or by fibrovascular bands no imaging will show you. The picture is different, buttock-dominant pain, and sitting is the enemy, not coughing. Martin and colleagues in knee surgery, sports traumatology, arthroscopy in 2014 measured exam maneuvers against endoscopic confirmation. The active piriformis test and the seated piriformis stretch test used together reached 91% sensitivity and 80% specificity. Scope that honestly. 33 subjects, one center, retrospective, run by the test's own developers, a signal worth having, not general population performance. In that same series, the straight leg raise was 15% sensitive. It misses this. And FADIR, constantly ordered up as a piriformis test, is a hip impingement test. Generator 3 is the one almost nobody checks for, because checking takes a thumb in 30 seconds, and nobody has budgeted either. The superior cluneal nerves branch off the back of the L1 through L3 nerves, run laterally across the low back, and cross the iliac crest through a tight tunnel of bone and fascia. They start at your lumbar spine and get pinched a hand's breadth away from it, which is exactly why this gets read as a disc. Irritate one and you get back pain radiating into the buttock and down the leg. Cunha and colleagues, in the Journal of Orthopedic Surgery and Research in 2014, screened 834 patients who came to a single Japanese center with low back pain, leg symptoms, or both. 14% met screening criteria for a suspected superior cluneal nerve disorder. 49% of those had leg symptoms. A purely sensory nerve cannot weaken your calf or abolish your ankle reflex. So when leg pain comes with a normal neurologic exam, that crest deserves a thumb. Here, nothing is injected until the generator is named. That means a history that asks what sitting does and what coughing does, then an examination. The crest palpated for a tender point, the piriformis loaded actively and in stretch, strength, reflex, and sensation checked against the implicated dermatome. For a root, I want concordance, pattern, findings, and film naming one level, and imaging is only one of the three. Where the picture stays ambiguous, a block is a diagnostic instrument. Under ultrasound, we see the sciatic nerve in the deep gluteal space or the cluneal branch at the crest and place a small volume of anesthetic. Its limit, a single uncontrolled block carries a substantial false positive rate. Anesthetic spreads, An expectation is powerful. When the crest or the deep gluteal space is the answer, the treatment is not an epidural. It is ultrasound-guided hydrodissection to free the nerve from what is tethering it, paired with loaded rehabilitation of the hip rotators and rebuilt sitting tolerance. The hydrodissection buys the window. The rehabilitation holds it. When the generator truly is a compressed root and conservative care has failed, a transforaminal epidural is done under live fluoroscopy with contrast, so I watch medication outline the correct route before steroid goes in. Its anti-inflammatory action in humans is plausible, not proven. Oliveira and colleagues in the Cochrane database of systematic reviews in 2020 pooled the placebo-controlled trials in lumbosacral radicular pain. Every epidural route together, interlaminar, transforaminal, and caudal, not this approach alone. Steroid beat placebo by about 4.9 points for leg pain across 8 trials and 949 patients, and about 4.2 points for disability across 12 trials and 1,367 patients on 100-point scales at 2 weeks to 3 months, moderate certainty. The authors judged that difference possibly not clinically important, and no long-term benefit was established. That is the honest ceiling. The window is still worth having. It is when rehabilitation happens. Now the risks, because you cannot consent to what has not been said. No corticosteroid is FDA approved for epidural or perineural injection, so every one of these injections is an off-label use of the drug. The labeling warns of rare but serious neurologic events, including spinal cord infarction, paralysis, stroke, loss of vision, and death. More commonly, a temporary increase in pain, dural puncture headache, transient blood sugar elevation, adrenal suppression, flushing, insomnia, infection, and bleeding. Epidural hematoma is why every blood thinner must be on the table before anything is scheduled, along with active infection, uncontrolled diabetes, or a bleeding disorder. A deep gluteal or cluneal block can leave the leg temporarily weak or numb, so you are not driving yourself home. Where metabolic inflammation is part of your terrain, we address nutrition, but ketogenic nutrition, omega-3 derived pro-resolving mediators, and red and near-infrared light remain adjunctive and unproven here. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. 2 years aimed at a disc, 3 lumbar epidurals, therapy built around it, imaging showing a bulge half of you would also have. It is worst after 20 minutes in a chair, but the pain stays parked in the buttock and never crosses the knee, and coughing does nothing to it, neither of which fits a compressed root. Both piriformis maneuvers reproduce it. A tender point on the crest lights up the limb. 2 positives, 2 candidates. We blocked the crest first, the smaller question, and it gave several hours of clear relief, informative, not conclusive. A second block, a different day, did the same. That moved the crest from possible to probable and the disc off the list. Weeks of work, not one appointment. Then hydrodissection at the crest and the part nobody enjoys. Months of hip rotator work, sitting tolerance rebuilt in 5-minute increments, a setback after a long drive. The pain did not go to zero, and I would not promise that it would. What came back was the ability to plan a day without measuring it in chairs. One warning first: progressive weakness, a foot that drops, numbness in the saddle area, or any change in bowel or bladder control is not a clinic appointment. That is an emergency, and you go now. Otherwise, if leg pain has outlasted every treatment aimed at your spine, the hour worth buying is the one where somebody names the generator. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Before you consent to one more injection, ask one question and hold the room until it is answered. Which of the 3 is generating my pain, and how do you know? If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.